Good afternoon to all. Thank you, Dr. Risha, for having me here, and thank you, audience, for bearing with this heat and staying with us through this session. So, we will talk about uveitis in a child in this session. Childhood uveitis is not very common. Its incidence is only about 3 in 1 lakh in 0 to 4 years and 6 in 1 lakh in 10 to 14 years. The most common cause is idiopathic, though you can have chronic anterior uveitis, and in 8 to 16 years you can have intermediate uveitis as the commonest presentation. The common types of uveitis by age is JIA in 0 to 6 years, idiopathic in 7 to 12 years, B27 associated uveitis in the older age group. We use the same classification as in the adults, IUSG and SUN classification, based on an anterior, intermediate, posterior, and pan uveitis anatomically, acute, chronic, recurrent, granulomatous, and non-granulomatous. They have the same features, so we will talk about how they can present first, and then we will go into specific pediatric uveitic entities. So you can have the keratic precipitates, the festooned pupil, posterior subcapsular cataract, pigments on the anterior lens capsule, and peculiarly in children, because they present very late, we have this finding in the cornea called the band-shaped keratopathy. Causes of uveitis in children include JIA, juvenile spondyloarthropathies. There's a long list, so I will not go into that. Intermediate uveitis can be idiopathic as in pars planitis or secondary to sarcoids, Behçet's, Lyme disease, and multiple sclerosis as well. Posterior uveitis, again infectious, non-infectious, the whole gamut has already been covered. Toxoplasma can present in children just as it can be in the adults, and TB as well, TB granulomas, TB abscess. One of my previous speakers touched upon this. So this is one case of 8-year-old boy, decreased vision in the right eye since 2 months, no history of redness, pain, joint pains, or any other systemic symptoms. Visual acuity was only 2/60 with an early band-shaped keratopathy, festooned pupil, and a cataractous lens, and we could not see the fundus. So B-scan showed that there is no retinal detachment or choroidal thickening or tumor, and he was sent to the immunologist to rule out an infective focus. Basic infective workup all came up negative, so we started him on immunosuppression, and he underwent cataract surgery. After cataract surgery, we found this. In the periphery, there was a granuloma-like lesion. And a clinical diagnosis of toxocara granuloma was made, and the patient was put on albendazole. And post-operatively, visual acuity was good, but once the steroids were stopped, the patient then had 2/60 in the right eye with a severe flare-up of inflammation as well as a retinal detachment. And so we went in and did the surgery, and a small biopsy of the granuloma was taken, and we actually did get the toxocara organism from the biopsy. They can also present with vasculitis in the fundus, arterial vasculitis, periphlebitis, combined vasculitis, and in children we should also be aware that some of the tumors can present with uveitis, retinoblastoma. Sometimes retinitis pigmentosa can be mistaken because they will have pigment dispersion in the anterior vitreous, chronic retinal detachments, leukemia, lymphomas, juvenile xanthogranulomas. Let's go into specific entities. Juvenile idiopathic arthritis is the most common systemic association of anterior uveitis in children. The risk factors for ocular involvement are females, oligoarticular arthritis, young age, ANA positivity, and RF negativity. It's usually bilateral and usually non-granulomatous, and usually presents with the complications because they are completely asymptomatic. So they will come with band-shaped keratopathy, cataract, posterior synechia, secondary glaucoma, sometimes as cystoid macular edema, and amblyopia. And they are completely asymptomatic. So like I said, it's a white eye and they present with complications. The first line of management is methotrexate and oral corticosteroids, and then depending on severity, MMF may be added later. Recently, adalimumab has been given, has got FDA approval for use in refractory cases. The topical medications in these cases have only an adjunctive role, and if you need to give more than 3 drops in a child for more than 3 months, the child should definitely be on systemic immunosuppression. So slow tapering of the topical steroids with monitoring and screening of all GIA in children are essential. Juvenile spondyloarthropathies make up 15% of the pediatric uveitis, which include juvenile ankylosing spondylitis, Rheita's, psoriatic arthritis, ulcerative colitis, and Crohn's disease. It usually affects boys more than 8 years of age, acute recurrent uveitis that is bilateral and asymmetric, and they are positive HLA-B27, but most are RF negative. They can also present with a severe acute anterior uveitis and hypopyon formation. IBD, it is inflammatory bowel disease, Crohn's and ulcerative colitis are associated with ocular inflammation in a minority. Sarcoidosis can present in childhood, again presents with granulomatous anterior uveitis as its typical findings, and complications like band keratopathy, cataract, and glaucoma. Inflammation of the posterior segment in the form of vasculitis or multifocal choroiditis can be seen. This is periphlebitis in sarcoidosis. Okay. So we'll go on to another interesting case. A 10-month-old female baby presented with abdominal distension, recurrent loose stools, progressive skin lesions, and failure to gain weight. The general examination showed pallor, edema over hands and feet, depigmented hair, hypopigmented scaly lesions, oral candidiasis, and this was the ophthalmic examination picture. Bilateral anterior uveitis, festooned pupil, multiple posterior synecdoche, and scattered lens opacities in both eyes. Investigation showed anemia. Skin biopsy showed some ill-formed granulomas with Langerhans giant cells with no caseation. Liver biopsy showed granulomatous inflammation with Schaumann bodies. This is the histology of the skin and liver. Stool was positive for occult blood, and endoscopy showed granulomatous duodenitis and colitis. And the child was this NOD2 gene mutation positive, negative, which means we were suspecting Blau syndrome or infantile sarcoid. Since the mutation came negative, our diagnosis was infantile sarcoid, and the child improved well with systemic immunosuppression and topical steroids. She underwent cataract surgery in one eye and is doing well now. So early onset childhood sarcoid can occur within the first 4 years of life. It is rare, but it appears to be different from sarcoid in older children and adolescents. And liver biopsy is an important diagnostic tool. And they usually present with this characteristic triad of rash, uveitis, and arthritis in a child younger than 4 years. And when it is autosomal dominantly inherited, it is called Blau syndrome. And it is also same triad, but they will be mutation positive. Behçet's uveitis, pediatric Behçet's is again uveitis at the age of 16 years or younger. Mean age is late childhood, male preponderance, family history may be there, bilateral involvement, recurrent panuveitis with retinal vasculitis. What do we do for these non-infectious uveitis in children? So we can give topical corticosteroids, but always remember that is not the mainstay of management, and you do need to give the systemic treatment. Periocular or subtenon corticosteroid injections can be given for intermediate or posterior uveitis, especially when you have unilateral cases, or for treatment of CME. Treatment of complications forms a major part of our treatment role in these children. You have to do cataract surgery when it is required, and it always be careful because severe exudative reaction is the norm. You have to step up systemic immunosuppression 2 weeks prior, give them systemic steroid cover, slow taper of both systemic and topical, and you may need to continue topicals for more than 6 months in these children. For band-shaped keratopathy, EDTA chelation or PTK can be done. For CME, you can give either the posterior subtenon if possible, or you can use the dexamethasone implant. I will stop with this last case, 12-year-old girl, bilateral panuveitis with vitreous haze, complicated cataract, and BSK. Vision was only hand movements when she presented to us with ciliary shutdown and hypotony. And she had to undergo cataract surgery with vitrectomy and oil. And she now maintains 612 in both eyes, but we cannot remove the oil because she's at risk of detachment and hypotony. So sometimes you do have to go in for vitrectomy, sometimes for diagnosis, but mostly therapeutic when you have grossly reduced visual acuity due to vitritis. And with the small gauge vitrectomy, now we have less morbidity in these children. In conclusion, pediatric uveitis is a challenging subspecialty, and it requires close cooperation with the pediatric rheumatologist and ophthalmologist to ensure accurate diagnosis and optimum treatment outcomes. Thank you. Sorry for running. This meant for a longer presentation.
Thank you, Dr. Natasha. I actually have a couple of questions for you because I find pediatric uveitis, very difficult to treat. So Can you tell us, what's the role of systemic steroids? Do they have a role at all in managing non-infectious pediatric uveitis? That is the first question. And second is, very often we have to put them on biologicals. I find the pediatric population requiring biologicals more than the adult. So what's the minimum duration of,
Refractory.
of using adalimumab?
So, role of systemic steroids, unless it is indicated for the joint complications, especially in JIA. So, unless it's indicated from the rheumatologist side, I advise the rheumatologist to start the systemic steroid only for covering the period while the methotrexate kicks into action if the patient is treatment naive. So, sometimes for a period of about 2 months and then taper to maintenance and then usually tapered and stopped once the methotrexate has started acting. And along with that, I start the topical steroids also, and again taper over the next 3 months. And about adalimumab, yes, refractory to, we usually give methotrexate first, not acting, we add MMF to it. It is still not acting, usually we give a period of 6 months, unless the child has very poor visual acuity and we are expecting like these blouse and sometimes the panuveitis in Behçet's do not respond so well, and very rarely we have given it as first line also, but generally after waiting for 6 months.
Thank you, Dr. Natasha. I just want to mention a couple of points about the infectious versus non-infectious posterior uveitis. So probably that is the question, whether it's an infection or an immune-mediated disease. So any patient who is immunocompromised and developing a de novo inflammation, you should consider it as infectious. Any patient who is developing de novo inflammation after surgery or after hospitalization, it should be thought as infectious. And I think as Dr. Anabi already mentioned, most cases of retinitis is infectious. Of course, if you see hypopyon again, you will consider it as infectious. Anything which, doesn't quite fit in with, a particular pattern, again, think of infections. And last but not the least, lack of response to steroids, think of infection.